Hello and good evening, good afternoon, good morning, wherever you are in the world. I am Dr. Philip McMillan, and welcome to another LinkedIn Live show with regards to COVID-19, which is where my focus has been over the past year of 2021, and I hope to continue to share interesting guests with you all for 2022. Before I start speaking with Dr. Goddard, though, I wanted to take a moment just to highlight a very, very important point. And here we have the deleting of the COVID-19 jabs. I'm highlighting this because this was such an important issue in the past week. Robert Malone has been taken off the platform. Gert van den Bosch before this. I was the only person to interview them together, and that was a fascinating interview. This post has had 1,200 views and been seen by 74,000 people. And the point is, two of the greatest minds in COVID-19 have been removed from the platform. And at this point, we need to have them, the best thinkers, at the forefront. Listen, if the pandemic ends at this point, that's great. It's probably not so much of an issue. But if it doesn't, we need those voices who are not afraid of challenging the current direction to maintain probity. This is not a time for yes men. And that's the point of what I was saying at that point when I made that post. We need to hear as many voices in terms of working out the science and trying to find the best solutions going forward. And so that's my point to start the new year. We need to do better. We need to find ways of including everybody and working together as a team. And this is probably where the importance of bringing in Dr. Robert Goddard. How are you, Rob? Pleasure to have you here with us today. Before we start talking, do you mind doing a quick introduction of yourself?
Hello, Philip. Thanks for inviting me to this platform. Watched some of your presentations. Been fascinating. So my name is Robert Goddard. I'm an oral maxillofacial surgeon. So in the British system, that's a Mr. And I suppose elsewhere be noted as being a Dr. Robert Goddard. I work as a consultant in the northeast of England, in Hull. I've been here for the past almost 9 years. I initially was born and bred in the East Midlands before going to London, doing majority of my first degree, my dental degree in London. I did various other kinds of jobs around the country before moving to Trinidad and doing my medical degree over there, and then returning doing my specialist training in and around the London and East Kent region. I have a wonderful wife and two great children. One sort of in the early teens and the other one is in the mid-20s. I feel very passionate about those two individuals, and part of the things that I do is really to try and make things better, a better world for them to live in going forwards. I'm very passionate about that.
So that leads us right into one important question, as we're going to touch by COVID shortly, but what had inspired you? And I'll highlight that right on your shirt is your banner, but what was the inspiration for you at the beginning of the pandemic?
During the early stages of the pandemic, I listened to people. My job involves seeing patients in an outpatient setting. I socialize with people. And I recall having a discussion in the summer of probably 2020 with some friends. And they were having discussions about the negative impact of lockdowns on business. And that contrasted with the noise and the narrative that I was experiencing within the hospital setting in terms of health issues. So I saw that there was a big debate and a bit of a tug of war between health and wealth in terms of the concept. And I thought that it would be good to have something that binds people. So an in-law unfortunately died from COVID, but they had lots of medical issues. As I said, it was really trying to balance that because I was starting to see a divide in people.
Mm-hmm. And so that's what then led you into the concept of touched by COVID. And we can't see the badge, and I don't have a picture of it, but what does that badge represent? That's on the left chest of your top.
Okay. So when you actually see the design in more detail, the bit in the middle is supposed to represent the virus.
Mm-hmm.
There's a flower. It's got 5 petals, multicolored, fairly similar in kind of design to the Yorkshire flag, because I am working and living in Yorkshire. The colors of the petals are supposed to be a bit like the Olympic flag, to represent unity and diversity. It was hoped that the flower would act as a trigger for remembrance of those people affected by COVID, whether they die, whether they get hospital admissions, whether they had mental health issues, whether they were suffering economically. So that was the first element of it, remembrance.
Mm-hmm.
The second element, touched by COVID, the words. I wanted people to engage in the symbol and to converse with one another. I felt that these words were obtuse enough for people to question, what does touched by COVID mean? To look at themselves and look at others, discuss what being touched by COVID means so that they could better understand one another. I felt the divide, even before we went into major lockdowns, that were dividing people because we were alienating ourselves from one another.
It's interesting that you noticed that so early, Robert, because it seemed so far away at the time when we had the lockdowns and people were upset about the lockdowns. And I guess maybe because I'm in the health sector and we were busy working at trying to manage patients, but a lot of people were suffering at that time, especially from the business community, and they were very upset. So we were starting to see that kind of divide very early on, that some people were disproportionately affected by the changes that occurred with the pandemic.
What was very interesting at the time when I thought of this and designed and tried to spread the logo, people questioned whether they were actually touched by COVID, touched by the virus. A lot of people said, well, I've not got the virus, so I've not been touched by it. And I was trying to explain that we're all, if not touched by it directly, indirectly touched by this pandemic, and that it would go on for a long, long time. And throughout this, there's still always been this talk that it'll just be a short-lived thing. I foresaw that it was going to be a long haul ages ago, but people just didn't take me on.
What made you think that at that time? Because this would have been like April 2020, April, May 2020. What made you think that this wasn't going to be a quick sprint and then we're beyond it?
I don't know. I think I'm not sure whether part of my medical training with the idea of a virus. I think as well, when we were seeing the spread of the virus through Europe, with the numbers and with the issues with the health services crumbling, I thought there's no way that this is going to be a flash in the pan. And I believe that from an economic point of view, I can remember thinking to myself, if the world could go into a major recession in 2008 because some people were lent money, subprime mortgages in America, what will holding the world commerce at a standstill for such a long time? How long will it take to recover from that? And so I thought, from a purely economic point of view, it was going to last a long time. Bearing in mind, we're only just coming out of the 2008, probably about 10, 11 years afterwards. And certainly from a medical point of view, I didn't think that if you're having so many people dying and it was a virus, I thought it's going to last years.
Yeah, that is a very important point that I don't think we've properly started to face, is that we have to anticipate a new normal. I sometimes liken it to someone who's had a stroke and who was a racing car driver, and they ask you when can they get back on the track, and you have to break the news to them is that you would be lucky if you got back to drive a car, much less to drive on a racing track. Is that about where we are now? Have we had a major stroke?
I think we have, and it's going to be interesting to see how we move forwards. But just moving on from the touch by COVID, the words, it was my hope that people would be passing that message on, the emblem, be wearing it, so that when they bumped into each other in the supermarket, although they were going to keep their distance, they would still keep communicating. Social distancing as a concept, I found, was the words used, if people were too literal, would not just think of it as being distancing one person from the next, but would be actually distancing themselves emotionally from one person to the next.
And this has gotten even more divided over the past 2 years now. And this is why I thought this was almost so on point as to where we are now, is that we really need to find ways to reconnect as individuals and as societies.
Yes. I've got some reflections. When I was invited to come to your program, I did think about what's actually happened from the initial concept of the touch by COVID, and my reflections on how people have been and how we've managed that. But I think I'll come on to that a little bit later on, if I may.
Yeah.
Very shortly. The third concept, other than the words, is the symbol of the shield. And that is to say, to symbolize fight against the pandemic. And when I say fight, I envisioned this as being to fight it in terms of the spread of the disease, to fight it in terms of the treatment of the disease, to fight it in terms of all the mental health issues that go on with it, to fight it in terms of the economic damage. And so with that in mind, that's why there's a shield. Now, at that point, the only fight that we had at that time was keeping a distance, wearing a face mask, and suggesting that we supported the economy responsibly without putting people's health in danger. At that time, it was hand cleaning and hygiene and so on. There was no vaccines at that particular point in time. And I could remember when the vaccines were mooted, that they're working on it and thinking, yes, that's going to be a great thing to have the vaccines. And I was all very excited, just like everybody else. But the vaccines seemed to come and take a while before they came. And for the vast majority of people, it was getting close to a year after the introduction of the virus to this country. Well, at least when we thought it'd been introduced to this country. And the death rate was high, but relatively speaking, considering we were not vaccinating anybody, it wasn't as high as anticipated. And actually, from my recollection, was just starting to dip a little bit. So I think now where we are, when we start thinking about what is the best way to fight the pandemic, I think it raises quite a few questions, and I hope to be able to ask you a little bit of insight with regards to that. But before we go on to that,
Yes, go ahead. Mm-hmm.
What the reflections on the two other points in terms of remembrance.
Mm-hmm.
With remembrance, I said, let us remember those people affected by the virus. And people have often thought about those that have died and those that have become severely unwell. And I think we should do it. It's really important. I think one of the issues, though, is the numbers of people that have died, relatively speaking, has been small. And so those people that really want to remember, even when you take into account their extended families and social contacts, it's still relatively small. And I'm starting to wonder whether or not the general population are really remembering all those affected by the pandemic. Just a question out there.
And so when you think, just to hold you on that point, when you think of being touched by COVID, do you include in that picture long COVID, or is it just COVID and deaths?
No, it has to include long COVID, just as it has to include mental health, just as it has to include people who become unemployed and become destitute. It has to include those people trapped in domestic situations where they're exposed to domestic violence. It encompasses all of those things and more. But do people associate things such as mental health as being how we're managing COVID, as an example? I'm not convinced that people are. I think that people have been a little bit, and understandably, afraid for themselves and their immediate family and friends, and therefore have not looked out. That was part of the critical message I was trying to get across with the Touched by COVID message. I believed at the time that people were looking too much inwardly and not involving and maintaining contacts with others.
So if you take that touch by COVID concept, which is a phenomenal, a beautiful concept, and one that the kind of thing that we need in the world, what would you want it to do at this point with regards to some of the societal splits that we see?
When I came up with the Touch by COVID, I already mentioned those three elements, but there was a fourth element as well, and that was, if I'm going to sell the equivalent of badges or whatever merchandise, that money would go towards charitable causes. And I've spoken to a number of people, and some have felt I'm trying to do too much, all in the same concept. People can't get their heads around doing all of those things with one concept. I still believe all of those things are important, and that's what it should really ultimately aim to do. But in the first instance, what I would like to do is I would like people to feel as much about the badge as, say, perhaps people feel about wearing a Manchester United top on. I want, and this is what I've really always wanted, was not just my local area or even nationally, but internationally, to have this being the symbol of fight, the symbol of solidarity, to unify people with the equality, diversity, and inclusion message. That's what I would ultimately like, because I believe that once you do that to start off with, people might then start looking a little bit deeper and think of some of the other concepts I'm trying to push through.
It is a challenging time now, because even at that point, there was the wealth and lockdown argument. Here we have wealth, lockdown, vaccinated, unvaccinated, and the whole melting pot together. And I have never seen a situation like what we are seeing now, where what it feels like is that you have two sides, and both of them are staring at each other, waiting on the other one to die. It's unbelievable. How do we manage to get beyond this divide?
I mean, the second part of the concept that I was going to discuss was the touch by COVID words. That whole idea of trying to encourage people to talk to one another. And I think you've hit the nail on the head. In this country, as in the UK, we had a fairly serious divide with regards to Brexit. It divided families, but somehow I don't even think that has divided people as much as COVID. We're now getting into the vaccination, not vaccination, how many vaccines you're going to get, and whether or not some people who may or may not be vaccinated, should they be treated as a second-class citizen? There's some significant divides. And there's also a divide in terms of just being able to talk and say something that's against the status quo. I've strongly wanted this symbol to encourage people to talk to one another. And fortunately, as I reflect, it's not been as successful as I would have liked it to have been. But at this point in time, I think it's more important than ever that we get back on track to open dialogue and open discussions. I was very sorry to hear of 2 people being banned from social media sites. I don't know what both of those people have to say. I'm not saying that what they're saying is correct or incorrect. What I'm saying is, unless it's so inflammatory that it's going to cause people to go out and kill and maim people, I believe it's important that the discussion lines are open and that people can think and discuss openly. If you don't, things just get driven underground, in my opinion.
I had to gap chat to this point because I thought it was very important. Any thoughts on how fear drives each side of this controversy?
I think fear is a really interesting point. There's always been a narrative of how dangerous COVID is. And I think that how you express that and how it's received differs from person to person. A perfect example of how fear has driven people to do strange things, I think, has happened in the last few days in terms of news from America. And you may say, well, America's America, that's very different to where I am. But 2 stories stuck in my mind. And I think it's driven by fear. One story is the American teacher that gave a student under the age of consent a COVID vaccine in their own home. The second story is how a parent whose child was COVID positive and that they feared for themselves took that child to a health institution with the child in the back of the trunk or the boot. Those 2 stories for me scream out fear. Or people doing things how they perceive it for the right reasons. This is worrying.
Yeah, I sometimes ask the question, and when China had their lockdown, I know that it was not even a concept that the Western world could ever do anything like that. It was just so far from reality. The question is, how scared must people have been at that time to turn everything upside down because of the virus? And that fear doesn't look as though it has disappeared.
No. I think in some regards, it's almost gaining pace, which feels a bit perverse when we're hearing of the figures of COVID in terms of death figures, not in terms of numbers, but in terms of death figures and hospital admissions. I think that we have good reason to be optimistic. hopefully.
You would think so. Yes, Omicron should give us good reason to be optimistic, not to drop our guard, but certainly to be optimistic about the what could be the future. But as I keep on saying, I think Professor Amitav Banerjee from India said something that stuck with me, and it has remained with me ever since. He said, "This is a marathon. Don't try and run it like a sprint." And it feels like we're trying to sprint our way out of the pandemic. And if you try and sprint out of a marathon, you run out of steam and you can't finish it. So more than ever, I think that we need to be prepared that this is a long haul. Hope for the best, but be prepared that it is the worst, which is that this goes on in multiple cycles over the next few years. We need to be prepared for that. Any thoughts on, is there enough resilience for that?
It's an interesting one. Over the past year, I did a number of podcast interviews, of which you were the first, actually. And one of the sort of founding questions I asked was, how safe did you feel when the pandemic first reached these shores? And then at more recent interviews, I also asked, and how safe do you feel now you've had the vaccination? And I just find it's very interesting because we often think about people as being one big homogenous group, but they are so different. You can categorize people, and you can start talking about the elderly, the young, the middle-aged, and you think and you believe that you have a handle on what people's fears are, but it's not until you start talking to them do you really appreciate how much fear they have. I think that from a personal perspective, I do tend to see that the older generation seem to have a lot more fear driving them forwards rather than the youngsters, which hopefully, if we move through this pandemic, is a positive one, because it is the young people that are our future, really.
Mm-hmm. I think that one of the things that I've realized when I speak about COVID, and I know what the fear feels like, because when one of my colleagues died in the first wave, I was waking up in the night feeling short of breath. I'd never had that before. It was a terrible experience. So I know what that fear felt like. And all I can think is that if people still have that kind of fear, that's what's driving the divisions, because people literally can't think beyond the fear, and that seems to be driving the divisions. And so the first thing that we have to do is challenge the fear. And one of the most important points that I keep on saying, COVID-19 severe disease is not random. That's what makes it makes it scary for people, is that it appears to be completely random. It is not random. And that's the most important thing that the science could do, is to help people to understand it is not random. Once you understand it, it helps you. Yeah. Mm-hmm.
Is it the science, or is it how it is portrayed? Because I think for quite some time we've known who are at higher risk, but I think that the message has often got a bit blurred as to which people are at high risk, which people are at medium risk, which people are at low risk. I don't think that is very clear for people. The average person almost has everybody having exactly the same risk. And I suspect that is why everybody is being treated in exactly the same way.
I think, and I'm reflecting now, there was a question. I'd spoken to a journalist, I think it was Teresa O'Brien, and I asked her a question if she could find at what point this question or this narrative changed. And the question was this: At the beginning, when we were getting the vaccines, the target was to protect the vulnerable. That was why we locked down. That was why we needed the vaccines. It was to protect the vulnerable. I think after the success of the first trial, I think it was beyond what they had expected. Somewhere in that moment, somebody thought, you know what, we can completely solve the pandemic with this. And then the narrative changed to we have to vaccinate our way out of the pandemic. I just don't know exactly when it changed. I don't know who changed it. I don't know when it was. I just know it changed. And it somehow drifted into a completely different direction because at the beginning, our whole purpose was to protect the vulnerable, and we knew who they were. How did that get lost?
Yeah. Working in the health service, what I can say in my managerial capacity, I was responsible for doing a number of risk assessments. And in particular, there was a big stress on people from ethnic minorities in terms of their risk assessment and the association of high mortality amongst those people. And I recently got something through at work effectively saying, actually, I think it was from the British Dental Association, pretty much saying that there isn't now no real recognized difference in terms of your mortality with ethnicity in terms of genetics, but it's more that it's related to lifestyle and social circumstances.
Mm-hmm. Yeah.
Which, if that is indeed the case, then again, we are, as far as I can see, we're almost 2 years down the line. Do we not have any information to say which people are more likely to be stricken down by this than others? Yeah. I believe I've seen some data, but I don't think it is widely acknowledged. I think that people still believe that it's random.
Yeah, this is a very, very important point, and I think that the issue that has been lost is that we can predict in terms of which group is most likely to be affected. I use the example here, and I was thinking about this earlier today. I use the example of neonates. Now, for those who don't know, a neonate is 0 to 28 days. That means they've just been born, and they are up to 28 days. You call them a neonate, and then they become an infant. These little babies have very poor immune systems, but they don't die with COVID-19. I think only 2 infants died in the whole pandemic in the UK. And so the question then becomes, if the virus is so lethal, how can it be possible that those tiny babies with very weak immune systems don't die? And once you get your head around that and you realize that the virus doesn't actually do the damage, it's the immune system. It's our immune response to the virus, kind of like what can happen with a bee sting, a hypersensitivity response. It's not the bee, it's your immune system. And that's where I think people need, this is where the science has gotten completely lost. I don't know why we don't spend more time educating people about what the science is.
As a surgeon, it's often been said that surgeons kind of treat the next patient very much like they treated the last patient, because they remember the successes, but they also remember all the adverse outcomes. And so they tend to transfer that onto the next patient. And I think something which I found very interesting over the past couple of years is anecdotal cases having more power than sort of statistical sort of basis. I don't really understand why that's been the case and continues to be the case. You will always find one outlier. The question is it 1 in 10, 1 in 100, 1 in a million, 1 in a billion? I found it very, very strange how people are interpreting statistics. I wonder if you can help me out with something. So when I did my podcasts, the podcast tended to have, the interviews tended to be a very formulaic pattern. Life before, life during, life after the pandemic, and what do people feel would be a better way to manage the situation, whether that be the economic situation or the health situation. If we talk about the health situation, what are the various options that could have happened? If we say that there was those that are fully vaccinated, as an example, those that are partially vaccinated, those that are unvaccinated, do we have evidence to suggest what would have happened in those three groups?
Well, it's one of the big challenges now, because certainly with regards to our trial data, normally you have a control group and you have a placebo group that you can then follow, but that has also been dismantled with regards to the pandemic, so that the people who are in the placebo group getting the vaccine is no longer there. So we don't actually have any direct comparisons in a proper study between, say, someone who is vaccinated, someone who's not. At the moment, I think that we can only look at countries. Sometimes there are some countries that are well vaccinated, some that are not, and then look at what some of the outcomes were with regards to the impact. Additionally, we can probably look at what happened in the first wave of the pandemic to get a good idea as to what would happen if we don't have any other intervention. And we could see, when you looked at the US statistics, I think that what was clear, I think it was 97.4% of the deaths had at least one comorbidity. And so age and comorbidities were the primary drivers for severe disease. And younger people tended not to get severe disease. And that was a very, very important differentiation that we have seen throughout. The problem is that, as you said, the anecdotes, there are some people, young people, who then get severe disease, who appear to have no comorbidities. And that's when it makes COVID-19 look random. My rule is always the same. It is never random. There is always going to be a very specific reason as to why that person had a severe immune response. And it's that randomness that people are afraid of that drives the fear. And so this is why I've always focused on, we've got to get to the bottom of the science. If you get to the bottom of the science, you can predict pretty accurately who is at risk. And then when you have enough therapies available, even if someone got sick, you can treat them. Then people don't get afraid.
I think that I recall at the beginning of the pandemic, I did a presentation for children, for school children, promoting the Touched by COVID. And I recall putting up figures. I did the talk around about November time, and then I repeated the talk in about March time, and the difference in numbers was enormous. But in that presentation, I put a slide up that had people that had been touched by COVID. And in the slide, there were about half a dozen people. And I said, some of these people had COVID and died. Some of these people had COVID and lived. And some of these people died or had financial problems or other issues. But they've all been touched by COVID. And I put it to them, can you say which one's which? And I recall one patient there, this little old lady. She looks about 90, and I'm pretty much sure that everybody who looked at that would have thought, well, that person died. And they didn't. But there was no hoo-ha about it. There was no, oh my gosh, we have a 90-year-old who's survived COVID and didn't really get any major issues. And I also recall having a friend of my mother's who was in that kind of age bracket getting COVID and thinking, oh God, well, that's a death sentence. And they survived. And we started seeing a lot more in the first wave of people that were older, which a lot of people went, I can't believe them. They've gone through it.
Yeah.
And I saw similar things when I had to go into my little stint where I was redeployed out of my maxillofacial world and to covering the COVID wards. I saw a similar thing there too. Now, I'm not saying that all or the vast majority of older people got COVID and survived. But what I'm saying is there's a little bit more of a stress in terms of whether someone lives or dies when they're younger. I think I have a similar thing when you talk about people dying of breast cancer as an example. When you ask people, are you more likely to die of breast cancer as an old person or as a young person? They'll go as a young person. Well, that statistically is not the case.
Yeah. Yeah, we tend to focus on when younger people die, and actually, the point you made there about the older people, I'll go beyond that point because as well, I was on the COVID ward seeing these patients. Not only did they survive, quite a number of them had no symptoms. I'm not even talking about that they were struggling, they were short of breath, they were on oxygen, and then they survived it. No, I'm saying they had no symptoms. They had literally no symptoms. They were COVID positive, no symptoms. These are the things that we have failed to address. We have failed to study. We have failed to differentiate why that older person died and this older person not even died, never had any symptoms. Those are very important scientific questions.
One of the things which has niggled me when I hear the term we're following the science is we're following a single branch of science, it seems to me. That's epidemiology. Mm-hmm. What other evidence do we have in terms of how well or poorly we are doing?
That's a big question, and it's one that I have been trying to get to the bottom of. And as far as I'm concerned, the only way that we can do that is all-cause mortality. That's what counts. What people are doing is that they're only counting the amount of patients who are coming into hospital with severe respiratory disease. That's useful to know, but the question still remains, are more people dying? Because I'll give you an example. If we put everybody on blood thinners, we would see less strokes, but we'd see a lot more bleeds. A lot more people would start bleeding. Now, if we weren't looking for bleeding, we would say that that intervention works. That's the danger when we don't look at all-cause mortality. And so just to highlight that point, here we've got, this is the European updated graphs and maps for mortality. And you can see here, this was 28 countries, including the UK, France, Germany, Greece, Hungary, Ireland, so everywhere in the UK. And I'm just going to highlight a few points that I think have stood out to me and things that we need to clarify. So here we have the 85-year-olds. Dark blue here is 2020. Light blue here is 2021. And gray here is 2019. So we can see in 2020 this sharp rise in April, May, where we are having deaths all across Europe. And then the second wave, more deaths all the way up. Makes perfect sense. And at the beginning of 2021, again, you saw a steep rise, and then it leveled off. And this was where we were getting the vaccines, and we're coming into the summer period in Europe, which was good. And then towards the end, we see a rise again. And one would have expected this to remain relatively flat, parallel to the 2019. But you accept that. It's significantly better than it was in 2020. But as we roll down, so this is the 75 to 84 age group. And what we can see here is that 2020 is very closely mirrored to 2021. And there's only a slight improvement between the two. How is that possible? We've vaccinated a significant proportion of Europe. Why would that be the case? What is even more worrying is when we look at this age group, 65 to 74. 2021 all-cause mortality is higher than 2020. Why would that be if less people are dying of COVID? And even if we look at the 15 to 44 age group, now this one here really boggles your mind. This is double what it was in 2020. This is 2021, and it's almost triple what it was in 2019. We need to understand these numbers. I don't know what the cause of this is, but I know if we're seeing all-cause mortality rising in younger age groups, we need to try and work out what is the mechanism. We need to make sure that we're not missing something that could be important. And that's what I've been pushing for, is that from my perspective, when you're doing, let me just put it another way. If I have a patient who has high blood pressure, I don't automatically put them on a blood pressure tablet. I say, try to exercise, reduce the salt in your diet, and see whether or not weight loss will improve your blood pressure. Stop drinking alcohol. If that doesn't work, then you put them on a drug. And the reason for that is because every intervention carries risk. There is no intervention that doesn't come with risk. And it's a very important concept in all aspects of medicine. We always try and minimize interventions because we know that the more we do, the more likely we are to have problems. That's just how it works. And in the same way, we needed to ask ourselves, why did we shift from the vulnerable to everyone? What was the reason at that time? And does that reason still stand today when we have Omicron?
Philip, I have a couple more questions. I'm going to abuse my position here. So, in terms of understanding how the virus works, do we actually have any other supporting evidence, such as, I don't know, histology or histopathology, to be able to work out what is going on? That's my first question. And my second question relates to the fact that today I read that the UK has joined a group of 7 countries that have passed the 150,000 deaths. And just for context, one of those countries was Peru, that has approximately half the population or a third of the population of this country. The other countries have at least twice as much, and it also includes the likes of India with 1.5 billion. How can that be? How can we have such differences in death numbers in places with different vaccination policies?
It is a big question. And as I say again, from a clinical perspective, if you take a disease like heart failure, which is very common, there are about 5 groups of drugs that we use to manage them. And it just depends on the patient's circumstance, their blood pressure, their heart rate, whether they've got an irregular heartbeat, so quite a number of factors. If you took only one of those drugs and you only use that drug, your effectiveness would significantly drop off because you need to combine strategies. In COVID-19, it can't be anything different. We need a combination of strategies. Vaccination is a part of that, and an important part, especially for the vulnerable. I think that I was stunned by what happened in Honduras, where I recently interviewed Dr. Valiero, where they developed a strategy to manage the fact that they had limited resources. And they have brought their COVID deaths down to technically zero. When I last looked at it, I'll check again. And they were able to use early treatment as part of their toolbox. The question remains as to why is it that in the Western, first world, we are so much against using any other strategies other than vaccination. Is it, I sometimes wonder, was it that the medical and scientific industry was so burnt by what happened with HCQ, where it became political? I don't know. I just know that we don't seem to be open to looking at what other countries are doing successfully and trying to emulate those successes. That's something that I recently did a post on, which is what I call the arrogant ignorance, where we perceive that what we know is best and we're not open to looking at other strategies elsewhere in the world.
One thing I was always struck by when thinking about people that were admitted to hospital, ITU, and had died, I was always struck by the fact that when people had COVID, I'd asked them, what did they do to manage an established COVID infection? What was the protocol? What were people expected to do? And certainly, I recall at the beginning of the pandemic, and I don't think it's significantly changed now. It's still stay at home. Well, I'm not too sure what anybody else actually thinks, other than having a lemsip. So, are we treating COVID infections, and are we treating it timely? Are we missing a time slot to actually do something about an established infection? I think it's all very well thinking about how to prevent the infection, but once you have it, do we still have any rules or lessons that we should be doing? If someone has a heart attack, you know, they had the Vinnie Jones advert on TV in the UK. People have an idea what to do. What do you do if you have COVID?
One of the important points that I found was missed from a research point of view, and this was my biggest worry in the first phase, that's before we started having the vaccines, was that we missed looking at asymptomatic COVID. So we perceive that when someone got COVID and they had mild symptoms, that it was a mild infection. And that's not what we see. This is the problem. There are only 6 autopsies that I found in patients who had either no symptoms or happened to have like a biopsy of the lung, or they'd taken out a lobe and were found to have COVID afterwards. And what they found consistently was that there was significant inflammation in the lungs, although the person had limited or no symptoms. And we saw a similar pattern with scans of the chest in children. Even though they had mild symptoms, there were still infiltrates in up to 70% of them that would look like a pneumonia. It's just that it was subclinical. That's the piece of the puzzle that we have missed studying. Because we don't understand that early phase of COVID-19 is why we don't grasp the later phase. And that's where people talk about the viral versus the immune phase. Once they come into hospital, that's the immune phase. And I think Dr. Shetty in South Africa demonstrated from his observations that at that point, if you intervene with the correct dose of steroids and antihistamines, nobody dies. And I don't mean a few people die. I mean, literally, nobody dies. And so this kind of information is out there. The question is why is it not being embraced across the world? Even if you didn't believe it, what does it take to give somebody an antihistamine as soon as they turn up in A&E? I mean, come on, Piriton, 8 milligrams, you just give it to them. What have you got to lose? There is absolutely no reason, if you are aware of those principles, that you wouldn't do something like that. And so, in the same way that antibiotics, now here's an important point. In sepsis, antibiotics don't work. They only work if you apply them early. If you have a patient who is septic and you go beyond the 6 hours, for example, if you delay the intervention of antibiotics, you would come to the conclusion that they don't work. And we know that in terms of bacterial infections. Why would the principles not apply in the context of a viral infection that's associated with severe immune dysregulation? Why would we assume that very early intervention would not be critical?
I mean, I find it very interesting from knowing GPs, thinking, why not give that as advice? I think patients are struggling to get in to see GPs, whether that's face-to-face or by a telephone call. And you'd kind of think that if there's something that simple and it potentially can do no harm, but I suppose what's happening is you're getting a double standard. If you don't think it can do any harm, why not give it? And that's a similar thing that's the argument for the vaccine. Well, we don't think it's going to do any significant harm, so why not give it? There's a slight difference in the fact that the vaccine is something new versus the antihistamine and steroids has been given for donkeys. But really, I suppose, why not give it?
Yes, I mean, it raises some very important questions, ethical questions. I think people would argue that if it's not part of a protocol, so if it hasn't come from our royal colleges, then people don't feel comfortable to do it. And that's a limitation that exists, because any doctor who then starts using it off-label is, in theory, at higher risk for litigation. Why stick out their neck? That's really fundamentally what patients don't understand, is the premise of defensive medicine. You will know it from a surgical point of view. A high-risk patient, you just don't want to operate on because it will mess up the numbers. And so in that sense, defensive medicine says it is better to do nothing, which is a problem.
And I suppose for me, this goes back to the touch by COVID message in terms of people being able to speak out. I think we're in very interesting times where people are reluctant to speak up in case of looking foolish, in case of reprisals. And as I said earlier, it is so important for us to keep the dialogue going. I believe that we should investigate everything. And I know we have time and financial constraints, but this is a very special time. I recall Nicki Minaj, the singer, talking about her best friend's cousins, whoever, saying that they had swollen testicles following the vaccine. And the Prime Minister of Trinidad coming out publicly saying, we haven't got time to waste to check on such nonsense and foolishness. I would argue that we should have time to check up on such things, because we don't know if it is that we knew so much about the disease that we know that it doesn't as a definite, or the vaccine that we know as a definite it doesn't. we should be looking at investigating. There should be scientists out there investigating these things on our behalf. I'm not entirely sure what kind of systems we've had in place. Certainly, I recall watching the film Contagion with absolute horror, thinking, oh my God, how long ago was this made? And it's pretty much exactly as it said in the film. But where do we go from here in the immediate, in terms of looking at vaccines, treatments, but where do we go in the future in terms of monitoring, in terms of prevention of this happening again? I don't know, and I put that question out to you. I'm not sure if any of your guests have shed any light in previous programs.
Yeah, I think that there are many different thoughts as to what can happen. I mean, I have my thoughts and my research on autoimmunity, but I think the fundamental thing that I emphasize all the time is that the foundation of Western medicine is histology and pathological examination of tissues.
Exactly.
If we are going to be investing any funds into anything, it's about examining tissue. If we have this much money sloshing around in the world that we can afford to do some of the things we're doing, I don't see why it's difficult to even get core biopsies of every patient. I don't mean some patients. And that's the important point. We need to be doing it on almost every patient because we need to understand what happens, especially in early infection. If we don't understand how the virus causes disease, we don't have any chance of solving what is happening. That's been the gap before, and I would strongly push that we've got a lot of autopsies on patients who have died, but we need
Do we?
tissue. We do have a good amount of autopsies that have been done on patients that have died, but sometimes patients die 30 days down the line. And so, therefore, you're going to be seeing a different pathological change in the lungs. That's a lot of fibrosis and so on. And so, it's not necessarily relevant to treatment. What we need is to understand the transition point. What happens right
I asked the
before a
question.
patient
I
gets
asked the
unwell?
question: do we have that many autopsies? Because I know that that some regions have not performed hardly any autopsies, and it's been quoted that from an expense point of view, we can't do it. And I questioned whether or not, when you think about all the numbers of major hospitals in the UK, if they even did one a week, we'd still have a fair number of autopsies to compare and to make deductions from.
Yeah, well, and don't forget as well that we still have to do coroner's autopsies. It's just that the results of them are sealed unless the families want to share it. So we do have some autopsies, but they're not the same as the detailed
Yeah.
autopsies that we would need with histological examination on the lungs, on the liver, on the kidney, looking for how the virus interacts with the cells. And this is what I'm saying is that we need those kinds of examinations at the transition point when patients go from being okay to being unwell. That 24-hour period is where we really need tissue examination to see exactly what is happening and to understand how we can intervene best. But without that kind of work, there is no shortcut. We need to put in the work.
I'm aware that I'm perhaps asking more questions, bearing in mind I'm supposed to be the guest. But can I ask another question?
Yeah.
Now, I think about vaccinations, and I think about the concept of it with cowpox, and I think of cowpox and smallpox. Question: could it be that the Omicron is the cowpox to the Delta smallpox?
Mm. Yes, it's quite possible. When we look at what seems to happen with Omicron, so I think from the papers that I've read, it seems as though the virus doesn't really affect the lungs that much. Okay. And it doesn't make sense. Why would the virus not spread to the lungs? It wouldn't choose not to spread to the lungs. So there must be something else that would explain that. The only thing that I can think is happening is that in the context of Omicron, it's not as good at evading interferon. So interferon is the signal that the body needs to know that it's got a viral infection. So if Omicron is only able to evade the signal for 24 hours, as opposed to, say, Delta, which could do it for 48 or 72 hours, by the time it's trying to spread to the lungs, the body is aware and able to block it. So therefore, it can only spread, but because it produces so many viral particles, it can still spread to the people around you. And so that is the only thing that makes sense. It's just not as effective at blocking interferon, which would then represent the ideal nasal vaccine, which is what I've always said. If you don't have immunity in your upper airway, it's too late to wait for the virus to hit your bloodstream. You need the protection in the upper airway so that the virus can't get down deep into the lungs, and so then you would not have severe infection. That is the most important thing. And guess what? The evidence from before suggested that, some of those patients who we thought with all the comorbidities who should get severe COVID-19 and barely have symptoms, the evidence seems to suggest that any prior exposure to a coronavirus relatively recently would protect against severe disease because the body would recognize any coronavirus. And so that's the power of the mucosal or the nasal immunity that I think is absolutely critical. So, yes, I think that is the big hope that Omicron could spread, infect everybody, and give everybody mucosal immunity. That's the ideal. However, I put one precaution in there. What I don't know yet is whether or not does the vaccine interfere with the ability to produce mucosal immunity? That's the next question. And we'll only know the answers to that if people start getting multiple reinfections. And so that's the bit that I don't know the answer for. And that's something that only time will tell. But we have to be looking for it. We have to be trying to see if we can find the answers for that. So yes, Rob, I think that's we should probably come to an end now. We've been talking for about an hour, over an hour now. We were aiming for about 40 minutes. So great that we have you. And I'd just like to emphasize again, touched by COVID is what we need for the world. We need everyone to be able to recognize that everyone has been touched in some way, shape, or form. We need to find ways to touch each other and to hopefully heal the divides.
Thank you, Philip, for saying that. If I could just leave with the notes to reiterate the Touch by COVID message and what's looking at trying to achieve and how listeners can help with that. They can help by spreading this symbol as wide as possible. The website's down, unfortunately. We only just found that out, but you can still go to the likes of Facebook, Twitter, Instagram, theoretically. Yeah. You can get information about Touch by COVID by going to those platforms. And hopefully by next week, the touchbycovid.com website will be back up and running. I would love to hear from some of the viewers, especially if anybody feels that they would like to volunteer to be a guest on my show. And I've recently been informed that they are looking at using some of the podcasts to put into the BBC archives. So you will be leaving something for future generations to learn from if you participate in the interview. So please come and contact me.
Wonderful. Thank you, Rob. Really appreciate the time. Thank you, everyone, for the beginning of the 2022. I hope to be able to sharing more interesting speakers with you all over the next year. Have a great evening to everyone.